Lowry Order today. The Oration was established in 2016 to honor the executive director, Nonie Lowry, and is honoring and recognizing her energy, guidance, unwavering support, and dedication to the Western Surgical. Dr. Johnson is currently medical director of the Legacy Health Systems Cancer Institute and the Legacy Breast Health Centers in Portland, Oregon. Her passion to care for others took her to Howard University in Washington, D.C., where she obtained a bachelor's degree in radiation therapy technology. She went on to matriculate at the Medical College of Virginia, now VCU in Richmond, and completed her residency in general surgery at LA County, USC. She returned home to St. Thomas at the behest of the governor and spent a brief time in the Virgin Islands serving as the Commissioner of Health for the territory. Dr. Johnson is a spork. She was recruited to Oregon to join the medical staff at Good Samaritan to help organize the development of breast health centers and to advance the care of cancer patients. She pioneered the introduction and training of surgeons in Oregon on sentinel node biopsies and has continued to model innovative breast cancer care, prompting her to receive the prestigious Oregon History Maker Award. Being raised by parents from humble beginnings who challenged her to see a bigger world and to extend love, she has a passion to make access to excellent, affordable, and equitable health care possible for all. She believes with dedication, ingenuity, and focus, we can make this a reality. I have the privilege of having my residents be trained by Dr. Johnson and happen to know she is incredibly dedicated and has a unique relationship with her patients both in and out of the operating room. It is a pleasure to introduce our Nonie Lowry Order, also the current president of the American Society of Breast Surgeons, and an opportunity for me to continue our efforts to see each other only outside of Portland. We rarely actually get to see each other in Portland. Dr. Johnson.
Thank you. It's truly an honor. Thank you, President Brazel and the program committee for just the honor of being here. And in thinking about who Nonie Lowry was and what she represented and her journey, I thought about, how was she held and supported through that time, and what would I talk about today? And I came to, what's love got to do with it? So this is a surgery club. So we're all going to be in the club. You know the song? So you got to sing with me. Oh, what's love got to do with it? What's love but a second-hand emotion? What's love got to do with it? Who needs a heart when a heart can be broken? The touch of your hand. Oh, okay, that's where that's where it ends. Okay. All right, how do I go forward? Oh, I got it. Okay. So I'd like to go through kind of why is empathy important in surgical practice, to talk about the differences between emotional empathy and clinical empathy, to recognize how treating patients with empathy improves clinical outcomes, and empathetic communication, how we pass it on. So when we're talking about empathy, what are we talking about? So let's define that. Empathy is the power of connection to one another when we are fully present listening with interest and compassion, and willing to share our understanding of another's experience. And this is different than emotional intelligence, in which you are aware of your own emotions and that you can also read the room, like understand the emotions of others. But to do that with empathy and compassion is a deeper thing. So why do surgeons need to talk about empathy? Well, it's because currently we're not super great at it. There was a study done that showed that surgeons miss about 62% of opportunities to acknowledge patients' feelings and fears. And of course, when a patient comes to see a surgeon, something invasive is about to happen. So it would be normal for people to have some kind of trepidation, and many times they don't know a lot about what's going to happen to them. And only about 38% of the time do surgeons positively respond if they pick up on the clue that the patient needs some reassurance or emotional support. So why does empathetic communication improve outcomes? Well, it definitely is associated with better patient outcomes on numerous studies. And empathetic communication, and I just talked about listening, means that you actually take a deeper and better history. So when you walk in the room and you don't ask a close-ended question, like for instance, if you're seeing somebody with an appendectomy and you come in and say, are you having right lower quadrant pain? That's basically a yes or a no. But if you come in and say, can you tell me about your symptoms? When did they start? How did they feel? Where were they? Then you get a much deeper, richer history. The patient tells you a lot more. So you become a better diagnostician. Being an empathetic communicator and treating your patients with empathy, you get better patient outcomes, you get better patient satisfaction, and you get satisfaction yourself. So it lends to less burnout, and it does lower your malpractice risk. So physiologically, how does empathetic treatment improve outcomes? Well, it may have something to do with even improving immune function. So this is a study that's quoted very often in the literature on this. And it was a study on patients that came in with a cold. So they looked at 719 patients with new symptoms of a cold, and they were randomized to 3 groups. So one of the groups just had, like, the nurse say, take some Theraflu and you should get better in a few days. The second group actually saw a provider, but it was a very formal interaction and basically just said, you have a cold. These are the things you need to do. You'll get better. And then the third group had a empathetic consultation, where first they listened to the symptoms, said they understood they weren't feeling well, had eye contact, touched them, went through everything, and then said, if you don't feel better, let us know, but I really think you will. So made them feel better. And the result was, actually they swabbed their noses too. So they measured IL-8 and neutrophils. So the patients that had the empathetic interviews or the enhanced interaction, their IOL was much more robust, and they had much more neutrophils in their nasal swabs, and they were covered a full day faster than the patients that did not. So I think it does speak to having good interactions, and feeling good about it really improves the patient's immune function. So let's cut to the chase, shall we say, and talk about surgeons. So this study looked at 50 surgeons, 549 outpatients. And this study measured surgeons' empathetic scores as well as their emotional intelligence. And going into it, they found that emotional intelligence was good at patient-surgeon relationship, and empathy was as good, but you didn't see much of a difference between the two. But interestingly, post-operatively, the surgeons that had the most empathic communication and the patients felt empathy from them, they had higher empathy scores. Those patients had better clinical outcomes as well as better patient satisfaction outcomes. So post-operatively, empathy did really make a difference. How many people are fellows of the American College of Surgeons? I would trust that most everybody outside of the residents are. So we all took this oath to place the welfare and rights of my patient above all else. I promise to deal with each patient as I would wish to be dealt with if I were in the patient's position. Do you remember that? So why is the surgeon-patient relationship unique? Well, I would submit that it's because when you come to a surgeon, we are going to invade people most of the time. That's what we're going to do. So patients have to feel good about our skills, but it's more than that because you have to trust that the surgeon cares about you. And then when it comes down to it, they are going to weigh risk and benefit and make a decision in your favor. So to feel that way or to entrust someone with that care, you have to really feel that they listen to you. They know who you are. They understand your come from. They know what brought you to that place, what other things are going on in your life. And as I say this, I think about some of the studies that we heard, the gastric cancer and fatigue and symptoms after surgery, or how interventions for social determinants of health are supporting patients in their aftercare made such a difference. We as surgeons can pick up on those things. If we are empathetic communicators, we will know or understand where that patient lives and what they require. So what happens to empathy in surgical training? Well, most medical students in year 1 and 2 have really high empathy scores. But then they hit the clinical years. And once they hit the clinical years, those empathetic scores begin to fall. And they really fall precipitously in surgical specialties. I think we all remember how many people read House of God, right? The age and the LASIX, like there are all these things. They're actually kind of cynical rules which come from training. So we're taught these things. I don't know how many people have had the opportunity to read Red Blanket, but it was written by John Harch, a surgeon, and it's about surgical training. And I highly suggest it. It's really a treat. And I think you'd relate to a lot of it, but it also talks about just the journey through surgical training and what it can do to your heart in terms of empathy. So the question in some of the studies is, is it the chicken or the egg? Is it that surgical specialties attract people who are less emotionally expressive, or do we train the empathy out of our residents? So in this study, a review of empathy, the importance and its teaching in surgical training, they asked medical students to give descriptors of surgeons. And unfortunately, descriptor A was what emerged: aloof, severe, impatient, impersonal, a mechanic, a fixer. But I would say to you, if you had a technically good surgeon, which list would you want? Who would you want your family member to see? A or B? A surgeon that was engaged, warm, listened actively, was personable, was a thinker and a holistic healer. I would say I'd want B. So what is appropriate empathy in surgery? Well, I talked at the beginning, there's emotional empathy and then there's clinical empathy. We don't really want emotional empathy. Being emotional or really giving of yourself or really getting wrapped into a patient is not healthy. It can cloud your clinical judgment. It actually burns you out. And this is actually where you can get into biased care, because you tend to become more emotionally attached to people that you relate more with somebody who reminds you of your auntie or your best friend, or somebody you went to high school with. So that's emotional empathy, and we want to get away from that, and we want to get to clinical empathy. So clinical empathy means you're a compassionate communicator. It's again going back to what empathy is having insight into life experiences of your patient to really understand their come from and to ultimately be able to understand those things and speak them back to them so that you engender trust. To understand your patient without pity. So to understand them and their level and where they are. So I just put up a few pictures of mentors of mine that taught me clinical empathy. So there's Dr. Roy Schneider and Dr. Alfred Heath, both from the Virgin Islands, where I grew up. And I remember rotating specifically with Dr. Schneider and seeing a patient who had a vascular issue and a wound, and he had clearly given him instructions on how to care for it. And we saw him the following week and the wound looked terrible. And he said, your wound looks terrible. You clearly didn't take care of it. And the patient said, sorry. And Dr. Schneider looked at him and said, sorry is for old ladies who fart in church. I don't want to hear sorry. I want to understand why. Why did you not take care of your wound? Tell me what's keeping you from taking care of your wound. So he explained all the things that he had going on at home, the other people he was supporting, the fact that he didn't want to ask relatives for help. We had a really good discussion about it. We got some help for him. And the next week, his wound looked beautiful. So that was my first experience with that and understanding that you have to know what's going on with people outside of just the clinic. And then I want to talk about Dr. Tom Byrne, who is a member of Western Surgical Association and trained me at LA County USC. And I particularly remember him on rounds where he would touch patients or even sit on their bed. And he taught us that people were more than their disease. He taught us to see their humanity in all of it at County Hospital. And I'm eternally grateful to him. So I talked about asking open-ended questions. So 90% of surgeons ask closed-ended questions. So we want to do better about that. And when we're training our residents, we want to do better about that. So looking at these queries, would you tell me a little bit more about that? Or let me see if this is right. Something I often do is when I read a patient's history, especially if I'm doing a second opinion on something, I tell them what I have gleaned from their history. And then I say, did I get it all, or is there more that I need to know, or did I miss something? And that gives them the opportunity to fill in what they think is important or what they think I really need to know. So these are all things, really great ways to communicate with people and to be able to listen. So let's just, for fun, take a case scenario. So a surgical resident sees a patient who's 34 years old, 25 weeks pregnant. It's her first pregnancy in the operating room. Migratory right lower quadrant pain, elevated white count, positive CT. And he calls his attending and says, this is a 34-year-old pregnant woman, and presents the case. And the attending says, let's book her for an appendectomy. So he goes back to book the patient or get her consented, and she refuses to sign the consent. I think we've all been there. So this is one response. You can think, oh my God, this lady, she's just going to be difficult. And you go down to the emergency room as the attending and you say, look, you have appendicitis. If you don't do this surgery, you're going to be really sick. We're the doctor. We know what's best for you. You need to sign this consent. Let's get the surgery done. And maybe the patient does sign the consent, but how does she feel? Versus scenario B, where as an attending, you take a deep breath, you go in and sit down and say, can you tell me, what are your concerns about surgery? Can I answer additional questions for you? Then you hear, this is my first pregnancy. I'm really worried about the baby. And you can reassure and say, I understand that you're worried, but I really think the best thing for you and your baby is to have this surgery. So she signs the consent, but how do you think she goes to surgery, and how do you think she feels about her care later? So we've talked about empathy, and I bet you many, many people in the room think if you looked in the dictionary under empathetic surgeon, you would see your picture. How many people think you would see your picture? if we said empathetic surgeon. No takers? Wow. Okay, there, Lee. See, it would actually be moi. But even I have patients that really test this empathetic communication thing. So there's always difficult patients. And in the reading for this, I came upon this article, which I really enjoyed, and I would recommend other people reading. And it was written by a plastic surgeon, and he wrote it when he was in his fellowship. And it was the first time I hated a patient. And that's the one thing I want to also address, that, you know, you can do your best at empathetic communication, but you're going to meet one or two patients that really test that. And when you come on that, sometimes you have to extricate yourself and take a deep breath, be mindful, and do the best that you can. You're not always going to win every empathetic conversation. You're not always going to make every patient happy. But just because that happens doesn't mean that the next person you see, you can't approach it again in the same way and give that same heart. If you find that you are becoming short-tempered and not being able to listen to people, and it's being a struggle for you to do empathetic communication, it could be a sign that you're burnt out. So being burnt out will take away from your ability to do this. So if you find that, maybe it's time for you to step away and refill your cup, because you can't give to others when you're empty. So I hope that I've made a real case for why we need to be empathetic and why we need to teach that to our residents, fellows, and students, because being empathetic makes a good surgeon great. Remember to take care and listen, ask open-ended questions, and remember to understand your come from. When we're talking about implicit bias in medicine, if you really work on this, I think you will see differences in how we care for people, because we take it out of their group or where they're, and understand them as their human side, and look for that. Don't miss your moments to communicate and care. And one of the things that I learned probably about 15 years ago is when I had surgery myself. Right before I was going to sleep in the operating room, my gynecologist held my hand while I went to sleep. And that was the most powerful thing to me, because she was the only person I knew in that operating room. Think about it. When we take patients to surgery, you're probably the only person they've met before. The anesthesiologist is new, the scrub and the circulator, everybody else is new to them. And that is a very stressful situation, getting ready to undergo anesthesia. So just taking a moment to hold their hand. I know many of us are going over the films or going over the equipment, and we're not present with the patient as they go to sleep. But I remember that to this day, just my gynecologist holding my hand. And so from then on, every patient, I am with them as they drift off to sleep, because as once they're asleep, I can go over the films and I can do all of those things. And it doesn't take that long, but it makes such a big difference. Try it. So I'd like to end with this quote from Maya Angelou, who said, "I've learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel." So what's love got to do with it? I would say everything. Thank you.
Thank you. Thank you so much, Dr. Johnson. I had heard that you sang to your patients, but I really appreciate the opportunity to sing with you in public. We have this little token of our appreciation to thank you for a wonderful reminder to keep the patients at the center.
Thank you. Thank you.